Okay, everybody. Welcome to Sugar and Spice training on post-hip surgery replacement repair surgery. Yes. So we are making these videos. I'm Regina, Amelia Infinity. We're making these videos because we really want our Sugar and Spice team to feel very confident, educated, and informed and like just know that you have the skill set and the information that you need to take care of a patient that is fresh out of the hospital. So we're going to talk about specifically post hip replacement surgery. So Infinity, you want to start us off with,
Yes.
we'll go through our questions and then we're going to do some demonstrations.
Okay,
Okay.
perfect. So how are hip replacement procedures done and what parts of the hip joint are replaced during surgery?
So normally the places or the pieces that are replaced are there's a shaft, there's a ball, there's a socket, and then there's like a little plastic piece of cartilage that goes between the ball and the socket.
Okay.
So this part is a metal shaft, and there's a hollow part of the femur bone. So they're going to open up this joint. They will cut off the existing ball and shaft of the top of the femur bone. And then they will put in it's usually a metal one. So it's a metal ball and it's got a skinny shaft that goes down inside the hollow part of the femur bone where the bone marrow is. So they pound that down in there so it's tight. And then the pelvic girdle, their pelvis, has the socket part of it that fits in over the ball. And so this piece is replaced. It's like a porous type material that they will screw into the pelvis. And then over time, bone will grow from the pelvis bone into this encapsulated, um, what did I call this?
Socket?
The socket. Thanks. And then they're also going to put a little plastic piece in here that serves as like the cartilage, right? So there's a cushion between the ball and the socket.
Okay.
So all of that gets replaced.
Okay, that sounds very intense. And what are the most common reasons patients undergo hip replacement surgery?
So some are elective surgeries just because the hip joint has worn out. A lot of times it's just bone on bone from the pelvis. And so the cartilage has worn out. Maybe the ligaments are really inflamed. This part of the ball can start to deteriorate over time, especially if it's just bone on bone. Just over time from walking and walking and walking, walking, it just wears it way down. And so then it can get kind of sloppy and painful. So sometimes people just want to replace it because they're having a lot of pain and discomfort. And then the other reason is if they have a fall. So you may have heard sometimes people fall and break their hip, or they break their hip and fall. Have you heard it both ways? So if somebody has like osteoporosis or something where their bones are really fragile, sometimes they can break their hip and then they fall, right? So then a lot of times it breaks like right in this area, or fractures can extend up into the ball of the joint. So then in that case, obviously we're replacing it because it's broken.
Yeah. Okay. And how long does it typically take to recover from this?
I would say full recovery is usually about 3 months. And that's really has a lot to do with how they do the surgery. So if the surgeon has to go in through the back, we're gonna have some pictures for the actual training day of this, but um, they can either go in through and make an incision. Well, I think it's actually across this way in the back. Or if it's an elective surgery and there's no fractures that they're having to deal with, they can actually make an incision that goes up and down right here. And what's really awesome about the anterior approach is that they can cut and then pull a lot of these ligaments and tendons away from the site, and just they like kind of anchor them down during surgery, and then they can do what they need to do. It's a smaller access area for them, but if it's elective and there's not any fractures that they're having to really they know what they're getting into before they go into the joint. They've got MRIs and things like that. An anterior approach surgery is much easier to recover from because they don't have to cut the muscles, the ligaments, the tendon, all that kind of stuff. So it's a lot less trauma to the area to do an anterior approach. And then they can get in there and replace those parts we talked about. But if they have to go in posteriorly, then they're having to cut through a lot of muscle. I mean, this whole, I mean, you think, yeah, all of this is just, it's a lot, to have to cut through all those layers of muscle. And these are such important muscle groups for so much of what we do, just sitting up, laying in bed, if you're reclined, getting up from a chair, just it's a lot. So then they have to, connect all of this during the surgery, and that takes a lot longer and can be more painful for the recovery.
Yeah. So with the anterior, they just pull it aside and then it just goes right back.
Uh-huh.
Okay.
Yeah, pretty much. I mean, it still does some trauma to those ligaments and tendons to pull them, and then they're kind of
Right.
like anchored down.
Okay.
So you can have some numbness in that area from it just being pinched
That
for a
makes
while
sense.
and being in an awkward spot.
Mhm.
Like if you know how it is, like if you just sit on your knees for too long on the floor and your feet go numb and and then you get up and you're like, oh my God, it was my 30 minutes. And it feels like you can't bend your knee.
Mhm.
So if you can imagine being in surgery for an hour, having those muscles and tendons like stuck in a certain position for a while where they're not used to being and having like
Right.
hold and tension on them. Yeah. But it's still better than cutting them.
Yeah, way better. And what are what are the most important safety considerations when helping a patient move around the home?
Falling again would be one of the big ones. And then we're going to go through a whole bunch of um, ways to prevent dislocation of that new hip. So if they have the posterior procedure done where they've had to cut all of this, then it's not going to be tight. It's going to be fragile. It's just held together by sutures. And so this hip could very easily be dislocated. So we're going to go through what not to do. Basically, you don't want the person to, um, you don't want them to go past a 90-degree angle. So we have 90 degrees right here, but if if for some reason this angle gets smaller, then that can pop right out. So we don't want them to go past 90. So that's a big deal. So we're going to go through a bunch of um, ways to prevent that and things that would somebody would do where you wouldn't really think it'd be a big deal, and they're suddenly past that 90. If they have the anterior approach, then dislocation risk is a lot lower because they didn't cut through all that. So that support and that strength is still there and that structure is still there.
And then how much activity is encouraged during the first few weeks at home?
We are going to encourage as much activity as they can tolerate, really. It's surprising. I think you have it on one of the questions there, but it's really surprising. They want patients up and standing immediately. So sometimes within 12 hours of this surgery, they got them up standing on that new joint.
To prevent blood clots, right, too?
That's part of it, but it's mainly just to get those muscles moving, and you don't want them to lose any mobility, right? And after somebody goes through those kind of surgeries, their joints can, they want to freeze up. They don't want to move. So you want them to get moving as quickly as possible.
Okay.
Yeah. Right away.
And then what should caregivers know about prescribed pain medication?
So one of the main things that people are going to be prescribed could be a narcotic pain medication. So you're just going to be thinking about all the side effects, right? So with narcotics, you have altered level consciousness. Sometimes they're going to be a little bit dizzy, a little bit lightheaded. So they're going to be an increased fall risk. And then I think a big one too is constipation. They're going to be at a huge risk for constipation anyway, because when you go through a surgery and you have anesthesia, it puts your body to sleep, right? But it puts your bowels to sleep. So then it takes them a while to wake up. And so anytime you do that, somebody goes through surgery, everything just slows down. So then they're very prone to constipation problems. You had asked, what was the question right before this? Oh, how much activity can they tolerate? I don't think I really answered that. So they can get up right away, but I would say as much activity as they can tolerate. I think our patients are going to let us know when they've done too much. They may start having some pain.
Yeah.
They might just feel overly tired. Their body's been through a lot, it's trying to heal up um, from the surgery, and it's got a foreign body now in there. And so it's like on high alert. And so that all that energy from your body trying to heal is going to be focused on that hip joint. So I would say as much as they can tolerate, but we're not going to push them a whole lot those first few days at least. Um, they're going to be a little bit, well, I think we're going to get to this in a minute, but there's a whole list of things that happen when somebody just goes through a surgery. And so having the anesthesia in their body, especially for our senior population, the way that that gets filtered out is through their kidneys and their liver, right? But as we age, our organs don't function like they did when we were in our 20s. And so it's going to take a lot longer for the body to filter out all those extra chemicals. And so that can give them brain fog. It can make them lightheaded and dizzy. It can cause the constipation. And they might just be confused, just kind of disoriented and things like that from the anesthesia for 24 to 48 hours usually.
Okay. And then what signs of possible complications should caregivers watch for?
Okay, so we talked about constipation. We talked about being a fall risk, right? We're going to talk about more the dislocation of the hip. But other complications can be just thinking about going through the hospitalization. Let me look at my notes. Okay, so sleep is something that gets really messed up in the hospital. There's lights on all night, there's alarms going off, you're in an uncomfortable bed, you just had surgery, so you might be in pain. You may have other injuries that you're dealing with. If you just endured a fall, you might have abrasions and other broken bones, who knows? So I would just be cognizant that there's going to be they could be complex when they first come home. Nutrition is going to be a big thing to watch for. So if they're post anesthesia and their bowels are not waking up yet, they may not have much of an appetite. But let's go ahead and get some nutrition going, right? Because amino acids and protein are the building blocks to help repair this joint and the muscles. And so it's really important that we get that nutrition flowing. So even if it's just like a protein shake or what we want to avoid, let's say that what we want to avoid is like empty calories, right? So we don't want to be giving them a bunch of cake and ice cream and just crackers and things that don't really have nutritional value. So we want to focus on whole foods, fruits, vegetables, meats, healthy things that are going to get them their proteins back in their system. Hydration, you would think that they would be hydrated in the hospital, but a lot of people really don't. So we're going to want to make sure that they're staying hydrated. We're offering a lot of fluids. That's also super important for the constipation aspect with the pain medicine. We want to keep a lot of fluids going through that bowel. Also watch out for diarrhea, because a lot of surgeons will pre-treat with stool softeners and laxatives and things like that, but then some people panic and take too many, and then they're super worried they're going to get constipated, so then they take way too much.
Oh my God.
And then they're doing this, up and down with the roller coaster. They're also potentially going to come home with just a lot more stress. Anytime you're in the hospital, there's, life goes on, but now you're laid up in the hospital. And so then there might be pets at home that you're worried about. There might be bills piling up. There could be, all kinds of things that you would normally take care of at home. Maybe this person that had surgery is the caregiver for another spouse or children at home, and now they are laid up in the hospital. So there's like this stress of like being stuck in a hospital bed and not able to fix all these problems at home. So all of that, I go without sleep for a day and I got a whole new pile of stress, I'm gonna be in a different place, right?
Yeah, absolutely.
So just be aware of that and have some patience and kindness. They're gonna be pretty tired. Um, yeah, and then just we might be taking care of other wounds and abrasions and things too from the
So what
fall.
about the incision site? Do the
Oh,
caregivers
sure.
need to be aware of that and be looking at that?
So sure, what we're gonna watch are so when they come home, they're gonna have the interior stitches holding everything together, but on the
Mm-hmm.
outside, a lot of times there's just they sew the inside together, they'll pull the skin together, and then a lot of times it's steri strips. I'm doing a knee, but for a
Mm-hmm.
hip, just little strips of surgical tape that is going to be a whole bunch of strips that are lined over that surgical site all up and down. So there might be like 20 of those or 30 of those little strips. And so we just want to be careful. Those will fall off when they're supposed to, and that's
Oh,
totally fine. They usually fall off within, I would say, a week or so,
okay.
depending on if they're having a lot of friction from their pants being pulled up and down or
Mhm.
multiple baths or whatever, they'll fall off a little sooner. But we want to try to be careful of that.
Okay.
Yeah.
And then what if it were to get infected? Would there be signs otherwise than just an
Yeah.
oozing wound or,
Right. It
severe
shouldn't be.
redness or anything like that?
Oh, good, great question. So there, it shouldn't really be draining much at all. Any drainage might be seen under the steri strips, but for the most part, it should be dry.
Okay.
So if we're seeing a lot of drainage, if it's bleeding, obviously, if it seems like there's certain spots on it that start to get red and inflamed and they're warmer to the touch than the other skin around it,
Mhm.
swollen, that would all be signs of a potential infection.
Okay. And what if a client does not want to do their exercises?
Doesn't everyone? I think it's part of it is educating them, because we want them to understand that the longer they sit, the more mobility they're potentially going to lose long term. So with I know this is how it is with knees. I don't know if it's the same with hips, but if you think about it, if you're cutting through muscles and ligaments and all those layers that are in the buttock region, and then those tissues are growing back together. Um, they are going to, over the next, couple of weeks after surgery, they're going to grow where they are. So if
Okay.
you have, like for a knee, if you have somebody who has knee surgery and they're in so much pain and they don't want to move it, right? Then they're going to keep their knee between this angle and they're really not going to want to stretch it like they
Yeah.
should or extend it like they should. But those tissues are growing together and they are going to get more and more and more,
Mhm.
um, more filaments and little strands of tissue are going to grow and grow and grow and connect. And if you're only letting your knee go to here, then they're going to grow and it's going to get tight and it's going to get stuck and it's going to turn into like a tight scar tissue.
Wow.
And so you have to, while you have time in
Hmm.
that first early week or two of healing, you don't want these tissues to think that they can just knot up
Stop.
right here,
Yeah.
right? You have to get the full range of motion
Mhm.
early on, or you're never going to get it. And yeah, if you wait until it doesn't hurt and it's completely healed up, you're going to be stuck like this,
Yeah.
right? So same with the hip. So we want to get it to move quick.
Yeah. Well, that's a good motivator.
Yeah.
I would hope.
Yeah,
Yeah,
so
that would
maybe
be.
educating them. And if they have dementia, that might be another story. But dementia patients are actually easier, I think, for hip, because they don't know that they're injured, so they just get up and go.
Oh, right.
Right?
It's true.
But for somebody who knows better and they're working through that pain, we just really got to educate them. Like your tissues are doing what they're supposed to do and they're growing and they're growing and they're growing. And so if you restrict that, they're only gonna grow to here. Then you're
Hmm.
gonna be stuck like that. And then you're gonna be hobbling around on your knee that you
Yeah.
just went through all that effort to get repaired.
Right.
Right. So you want that full function.
Okay. And you sort of touched on it just a little bit in your comments, but what if the person has dementia that just had the hip surgery?
Yeah. So I think they're great because they don't know any better and they're ready to just get up and go. At the same time, they're not gonna remember the instructions to not go past 90.
Yeah.
You know, they're gonna want to bend over, they're gonna want to pick up stuff. Um, so that's where it might be really, really, really important to have extra caregivers or somebody with them all the time that they're awake, to constantly remind them because that hip can dislocate really easy, especially if they had the posterior repair. As soon as they bend over, you can see like it's putting strain on as it's stretching out the buttock muscles. And so these are already loose and just been repaired. So there's not that tight structure to hold it together. So they bend over and it can just pop right back out.
Yeah.
If that happens, back to surgery we go
How?
to have to put it back to in place again.
Jeez.
So
Okay.
then you have to go through all that hospital scene all over again and then go through the anesthesia. Anesthesia is really tough on patients with dementia. They're already confused, but anesthesia can add to that confusion. And for some of our folks, I've seen where it can take several weeks for those chemicals to clear out of their system to where they can kind of not have that brain fog anymore.
Yeah.
So you add that to somebody who already has dementia, it's just,
It's rough.
yeah, it's not good. But, so don't be surprised if you're taking care of a dementia patient and they have a procedure and they have to go through anesthesia and they come home way worse than they were. That's not abnormal, but at the same time, push those fluids. That'll help their liver and their kidneys flush it out sooner. And just hang in there, educate the family. Hey, this might not be their new normal. Let's give it a month or so and see if they clear. But with dementia, so the main thing, let's go over all of our little precautions. We just had a guy that had this happen, so it's all fresh in our minds. We'll go over this. So maybe you can pull the chair up, and I took this side rail off, so maybe face that way so we can see your hips. Okay, cool.
That good?
So yep. So you're at a perfect 90. That's awesome. Now the gentleman that we were taking care of is very, very tall. So when he sits in a chair like this, his normal position, like just raise your feet up. Yeah, if he was just sitting in that chair, he's already past 90. So occupational and physical therapy came in right away and they were like, we got to elevate this seat. So if you don't have a special wheelchair that's taller, they brought in some really thick like gel pads and put those under there. And that elevated him enough to get that 90 back in place. The other place that we have a problem is on the toilet seat because the toilet seat was the normal standard height, but when he sat down on it, same thing, right? His knees were like up here, so now he's at risk for popping that joint out. So they brought in a bedside commode and they set that over the top of the toilet because they could make the legs really tall, and they set that over the toilet so he sat on that to use the bathroom. The other thing is if he were to try to pick something up off the floor, you would have to stop him. Don't do that. Don't do that. I got it. The other thing that we want to talk about is standing up. So what do we always say to people when they're going to stand up?
Nose over toes.
Nose over toes,
Yep.
right? Well, how are you supposed to do nose over toes? Because that means you're going to have to bend, and now you're smaller than 90. So these folks are going to need more help standing up. So you're going to need to get your gait belt on and make sure that you're helping them so that they can get this first part up. And so we don't want to do nose over toes for this, which makes it hard because your center of gravity has to be over your feet to be able to stand up. But if you give them that support in the beginning, and maybe put their walker in front of them too, so they can immediately transfer their weight. Crossing the legs, right? So we don't want to cross your legs because again, pulling the knee across the body can pop the hip out this way.
Oh, so with that, it's not even the height of your leg, it's the movement?
It's both, yeah.
Okay.
You don't want the leg to go across the body because now it can pop out this way.
Okay.
So, but yes, you're right. When you raise your leg up, now you're less than 90. Also. When we'll do the bed one in a minute, but it's also important when somebody's in bed that if you're rolling them side to side, that they are not, one of their legs is not crossing over their body. So you're gonna want to put pillows there if you're having them laid down. Where may the sheet go? So people like this need help putting on their socks and their shoes. They need help with bathing because they can't bend over and wash their feet or their legs. Let's see, making sure the chairs are high enough. Couches, if people are at home, make sure that they're not sinking into the couch. That can be another problem. We talked about the toilet seat, shower chairs too. Make sure those are nice and tall, to make sure they're not bending over. Let's see. Oh, I think, did you ask how long? I would say 3 months for these precautions.
Okay.
Okay, so 3 months for this to all heal up sufficiently that we're not worried about it popping out again. Okay. Oh, and also don't turn the toes inward. So even this rotation
Okay.
turns that hip and can dislocate it.
Jeez.
So
Lots of things to be careful about.
don't do this. Don't do that. All right, so let's go ahead and get into the bed, and I'll pause this for a second and
Okay.
we'll scoot it up a little bit. Okay, so here we are. We're going to demonstrate some of the issues to be careful for of, again, a post hip replacement, precautions for the bed. All right, so we're going to pretend that her surgery was on the left side. So as she lays down, I don't want her leg to cross over her body. So
Because
as you-
typically that would look like kind of that twisting motion, right?
Yeah, so if somebody needs help, I could put this rail down. This pole I can't do anything about, but I could come next to her and help support her upper back, not her neck, right? I'm not gonna put my hand up here, but around the back of her upper back and then under her knees, and I could help turn and rotate her backwards. A little difficult with all this in the way. But for this, I'm gonna pretend that you know how to lay down. You can follow directions, and I'm just gonna help you with your hip.
Okay.
All right. When you're ready, just keeping this nice and straight, not crossing her body. Okay, awesome. So if she was on her back, we could get her comfortable. We could put pillows under her knees and that kind of thing. But what I want to talk about is if she's going to lay on her side or we're doing a brief change. So again, we'll pretend that you can roll over on your own.
Okay.
So
Which,
I want you to roll this way.
okay.
Because the
So-
problem is, yeah, so say you're gonna sleep on your side, and what we don't want to happen, we can go ahead and roll on over,
Okay.
is we don't want this, I'll let it happen, but we don't want this knee down here touching the bed, right? Because this is crossing over her body. It's the same thing that we're gonna try to avoid with her crossing her legs. So what we would do is just make sure that we've got lots of pillows here to support that leg so it's nice and straight and it's not crossing. If you're doing a brief change, what I would recommend is, especially if you're by yourself and you can't do all things,
Yeah.
is to maybe have her roll the opposite direction. Like talking, but I'm off camera.
Oh.
Have her roll the opposite direction so that, and we can't even see her face. This is
You don't
weird.
need to. It's fine.
As we do. You guys see your beautiful face. Okay, lay down. There we go. Sorry, guys. I've got this awkward pole in the way. But have her roll to the other side, and that way you can do what you need to do, and you don't need to worry about if this leg crosses the center of her plane is fine. And then you can kind of roll back and forth, but avoid rolling all the way over onto this side for brief changes. The other thing is you might be worried like, well, then I'm going to be rolling this person back and forth over their surgical site, right? And is that going to cause a problem? That's less risky than dislocating the joint. So I would say err on the side of maybe a little bit more discomfort. To lay on the surgical site is better than risking dislocation.
Yeah.
And again, you don't have to, leave them in a uncomfortable position for a long amount of time or anything. Just get them cleaned up, and I think that was it. Oh, the other thing is making sure that these toes don't turn in. So if you need to, we can put pillows under her toes so that they're also facing forward.
Oh,
We
yeah,
don't
'cause
want
even
her.
like where I'm at right now would be bad, wouldn't it?
It's not bad right now, but
Okay.
I could see how your foot could drop off and then rotate forward, and that's going to rotate that hip joint. So all things, just try to keep your patient straight. Try to keep their legs straight and then not go above 90. It's the biggest thing.
Okay.
All right. Hopefully that helps. And we'll also do some in-class training with y'all so you can get your hands on each other and practice.